question for you. Are you able to hide the images that don't have photographs, or we're not seeing names? That's going to prevent the black Joe Cafaro from showing up.
I don't know how to do that. I don't know that it doesn't give me an option to.
I will teach you that for next time then.
Okay.
There's Irene.
Alrighty. Hello, everyone, and welcome to today's virtual panel discussion brought to you by California Association of Healthcare Leaders. My name's Emily Rahman, and I'm your session host representing the National Office of the American College of Healthcare Executives. We're glad you're here. Before we get started, I would like to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session unless there is active discussion, at which point you may unmute yourself to talk. You can also submit questions through the chat function. If you are on the go during the session, please participate using the Zoom app. Please make sure to use the name that is registered for this Zoom session. Today's session is worth 1.5 hours of ACHE face-to-face education credit. Credit will be applied to your ACHE account approximately 2 weeks following the end of the session based on your live session attendance and completion of the evaluation. This session is being recorded and will be available within 48 hours by navigating to your My ACHE account and selecting My Online Learning from the helpful links section on the right side of the screen. Now to begin the session, let me turn it over to Lillian Chan.
Welcome, everyone. My name is Lillian Chan, and I am co-chair of the California Healthcare Association, the California Association Healthcare Leaders Bay Area Local Program Council. That's a very long title, but part of our committee's responsibility is to bring together individuals that you're going to be hearing from tonight to have a lively discussion on a topic of interest to healthcare leaders in our area. And we hope that you'll be enjoying this particular conference. If you don't know much about CAHL, we are the Northern and Central California chapter of the American College of Healthcare Executives. We represent 50 of the 58 counties, so we hope that there are representatives from all over Northern and Central California on this this particular video educational program. We also want to let you know that this CAHL series, there's a series of additional continuing education programs that we have. There's one coming up in a couple more weeks, so please follow our website, and hopefully you'll have signed up already on well-being for the healthcare professional. I think it's a very timely topic. But tonight's program is sustainability of healthcare organizations, especially integrated delivery systems. So we have a great panel, and my responsibility tonight is to introduce you to our moderator. I'd like to introduce Joe Cafaro. Joe is the Senior Vice President for the Hospital Council, representing the South Bay region. And she has over 20 years of experience in government relations with a focus on state and local issues. Previously, she was with Lucille Packard Children's Hospital and also the city of San Jose. Joe has the distinction of having received Women of Influence Award in 2013 by the Silicon Valley Business Journal for her contribution to the several boards and committees on which she serves in the San Jose community. So I wanted to make sure that I gave the moderator, Joe, and the panelists as much time as possible, so I wanted to keep my remarks very short. But again, welcome on behalf of CAHL, and for the organizing committee and all the people behind the scenes. Thank you so much for joining us tonight. I hope you have a great time hearing from our panelists. So I'm going to turn this over to Joe now. Thank you.
Hi, good evening. So thank you very much, Lillian. I'm not sure how I'm showing up to you folks. I had to call in 2 different times, so you may be seeing a black screen, so I apologize because my microphone wasn't working. So first of all, thank you very much for joining us, and let me welcome you. This is extraordinary times. I'd like to say thank you and also to congratulate you for taking some time to focus on yourselves to become better leaders. So thank you very much. Let me go ahead and start introducing you to our panelists. So we have joining today is Irene Chavez. Irene Chavez is the Senior Vice President and San Jose Area Manager with Kaiser Permanente, San Jose. She has over 30 years experience as a healthcare industry leader, currently oversees hospital operations for a 247-bed hospital, OP medical offices with over 400 physicians, 3,200 nurses, and healthcare professionals in Santa Clara and Santa Cruz County. She was previously a CEO of El Paso Specialty Hospital and CEO of Providence Memorial Hospital, where she held the COO and Chief Development Officer roles. She received the 2020 Latino Business Leaders Award and named Distinguished Businesswoman of the Year by Silicon Valley Organizations in 2018. Irene, welcome. Next, we have Tucson Boyo, is a CEO at Zuckerberg San Francisco Hospital and Trauma Center in San Francisco. So he's also San Francisco's Safety Net Teaching Hospital, which is San Francisco's Safety Net Teaching Hospital with the largest primary care center and the only level 1 trauma center. Currently, Tucson has served as the hospital executive leader, crisis response preparedness and emergency and emergent with the Department of the Public Health. So you could imagine he's extremely busy right now. And as we were joking a little while ago, he feels like he's had 7 years taken off of his life, just so busy right now with everything that's been going on. And currently he's actually transitioning to a new role of Senior Vice President of Hospital Operations at John Muir. Congratulations. Next, we have Mike Thompson. He's the Executive Vice President and Chief Transformation Officer at John Muir Health. His role is that Mike is accountable for care management, infrastructure, information technology, risk analytic capabilities, and strategies to align the physician network. That is a lot. Mike also serves as chair of the John Muir Health Executive Operations Council. Previously, Mike served as president and CAO of John Muir Health. So thank you, Mike. Thank you for joining us. So before we get started, one thing I'd like to do is to help our folks, the panelists, know who is in the room and now our virtual room. And that is to have a poll to say, for us to be able to see who are we speaking to. So if you could please go ahead and mark if you are a C-suite leader, a level leader, other clinical and operation leaders, business support leader, program manager, or consultant. Just give you just a few more seconds to go ahead. We got about 76% of the votes. Thank you. Why don't we go ahead, and I'm not sure if I have to share.
I just shared them.
Thank you very much. So we see who's our most folks are director leader level leaders. So thank you so very much for joining us. And I think this is a good poll for us to be able to see who is in the audience. Thank you. So why don't we go ahead and get started with kicking off our first discussion. So I'm going to leave this to whoever would like to answer first of our participants, and that is, what does the future, oops, there's something on my screen, sorry. There we go. So Let me start over. What does the future model or models of care delivery look like? What are the critical structures? What are the critical success factors in healthcare system of the future? Or what are the focuses that's driving the new care delivery model? Or much of the recent innovations in US health policy has been based upon fundamental beliefs that the higher level of integration will yield a more efficient healthcare delivery system. I would like to see what part of this answer either of you would like to answer.
Hi, Joe. This is
Hi, Irene.
Irene. Mike and Tosan, I hope you're okay with me taking the first attempt at answering this voluminous question.
Highly encouraged.
Thanks. So I want to first go with the question of what are the forces that are driving the model of care delivery? And I want to challenge us that it really isn't about new model of care delivery. Those of us who have been in healthcare for any period of time, and God help me, but I've been in the business since 1975, we've seen a thing or two. And so new is a relative term. And what we see in healthcare is the constancy of change because of the life aging process of our patients, because of the business demands, the economics of healthcare. Believe it or not, back in 1983, when DRGs were just coming out, everyone thought it was the end of the world, and here we are, we didn't all perish. And then there's also the technology and innovation forces that are leading us in various exciting directions. So I think when you think about care delivery models, they really become more elegant when they incorporate how do we address the needs of our patients in the moment and meet them where they are, be it at home, sheltering in place, or having to be in the public and fearful of catching COVID, and everything in between. So I think those are some of the forces that we're all dealing with, and would love to hear now maybe some additional components from Mike or Tosan.
I'm happy to jump in, Tosan, unless you want to grab it.
Oh, go ahead, Mike.
So Irene, that was really well stated. And actually, I do want to acknowledge everyone on this phone. I commend you for taking time away from your family this evening to really invest in yourself and your own leadership skills. One of the moderators said that up front, and there's no better investment you can make in yourself. And so I applaud all of you for participating and gleaning as much of the intellect from Tosan and Irene as you can, because that's where most of the pearls of wisdom are going to come from tonight. But, I think, Irene, what you said about meeting the patients where they are, that really resonates with me, because, the truth is, when I think about our health system, not surprisingly, the health system was built largely around having the patient come meet us where we are and kind of go through our processes. And we all know what kind of challenges that's created. And so, when I think about this question about what does the future model look like, I'm not sure it's a model, but I hope at John Muir Health, where I work, that in 10 years from now, I look at the way we're delivering care, and I hope it feels more like Amazon than it does Macy's. And by that, I mean, that we'll be helping consumers in many different ways make better personalized choices through omni-channel access points, that will be providing care virtually and directly to our customers in their home, maybe in their schools, maybe in their workplaces, maybe occasionally still in our hospitals and our medical and our physician office buildings. But you know, I see for us, I hope less dependence on bricks and mortar in the future, more focus on virtual or distributed care models, more care at home, certainly. You know, we're starting to talk about all of those topics in our organization, and it's raising a lot of questions about, wow, how do we rationalize this huge capital investment that we've already made in bricks and mortar for hospitals and medical groups. So I'll stop there for a moment, let Tosan jump in as well.
Yeah, absolutely, Mike. I really appreciate what you and Irene have mentioned. One constancy in healthcare, 100%, I agree, is going to be change. And we always need the ability to learn how to adapt. And I would say that COVID has exponentially forced all of us to evolve. You know, whatever was going to take 5 to 10 years before has taken 5 months. You know, I mean, telehealth is no longer a trendy thing that was going to happen one day. Now we're all forced to ramp it up, and the world did not end. And hopefully the reimbursement structures will actually catch up and be sustainable in the future. So when I think about the future of healthcare, I also concur with Mike. We want to see patients at the center and making sure that care is coming to them. So when I think about the future, I think about it being in 4 different lenses. The first being, how do we prioritize prevention every step of the way? The second being, how can we move towards more prediction? So if we know what can happen, how can we look at the probabilities of what is likely going to happen and make sure that we can address it before it becomes really serious? And then how do we make care more personalized? And then the last thing I would say is really, how do we bring all 3 of these things, from preventative care, predictive care, personalized care, and then superimpose it on a population? We've been doing pieces, you know, for the past couple of decades, but if we think about where COVID is right now and knowing that, you know, it's really good, things are going to be hard for at least till 2022. I mean, I've been living in the eye of the storm for the past 7 months of my life, and I can tell you that the next 18 months are going to be pretty much like this. So the question becomes, how do we adapt in a way where we can still put the patients at the center of everything that we're doing, address all the other acute care needs that are going to continue to be impacting our population, and then at the same time, make sure that we have the ability and the capacity to personalize it for each single patient that comes through.
Great. Thank you so very much. So one thing I do want to remind those who are participating is that the chat is here. And if you have any questions or follow-up questions you would like, we would go ahead and ask them for you on your behalf. So please use the chat if you'd like to follow up with any questions. So
I have another thought, Joe, just on this topic.
Please, please.
You know, I'm interested, Irene and Tosan, how you think about whether, I know at John Muir Health, one of the things that we've been focused a lot on is our Medicare population over the last few years. And as of this coming January, we'll have about 35,000 Medicare lives in a risk program. So we've been working a lot on, on trying to identify the high risk and rising risk patients who are driving a lot of the medical costs, who need a different model of care. And so we're starting to think about different populations going forward and developing different models. It's not different care delivery per se, but these patients have very different needs of intensity, of team-based care, of maybe home-based care. And so in particular, I'm thinking, you know, we've had a big focus on high risk and rising risk Medicare patients, and we've set up comprehensive care programs, which is kind of like an ambulatory ICU, which I know a lot of your organizations have. We've propped up a care at home program for frail elderly who can't come in. We've been expanding our palliative care programs. And so these aren't new. To Irene's point, these aren't new, but we're definitely packaging services and sites of delivery and teams that are more deliberately focused on unique populations, because we have to manage them different based on the way that the payment systems are working. And I feel the same way. We haven't done this yet in our organization. Tosan could speak to it, but I feel the same way that we're going to need to do that with Medi-Cal in different ways, our Medi-Cal populations, and thinking about different systems of care than we have today. And today, historically in our organization, just taking an ambulatory, our primary care, is sort of 1950s vintage, 15-minute visits, all the panels are filled up, all the patients are sort of kind of treated very similar. And I don't think that's going to work based on the way that we're moving into more risk-based, value-based care initiatives. I think we're going to have to segment our populations very differently and provide care and intensity of treatment differently. So I'm curious, Tosan and Irene, do you have perspectives on that?
Thank you, Mike, for the question. I think it's a great segue to the next set of questions that Joe has for us on the changes that are needed in healthcare. Joe, do you want to frame that and then we'll respond to it?
Actually, I was thinking of a follow-up question also. So if you may, please indulge me a little bit, because Tosan had mentioned, he feels like we've moved forward 5 years in these 5 months. And so if you had your crystal ball, what changes do you think are going to stick or are going to be accelerated even more going forward?
Yeah, the first thing that comes to mind for me, I anticipate in the near future, the ratio of televisits to in-person visits is going to significantly overwhelm the in-person visits, especially in the ambulatory arena. So in my previous life, I led the ambulatory care services for San Mateo County. And I remember creating the very first telehealth pilot for our patients who were farm workers that leaving their job to go to get an appointment is going to be risky for them because they might not get paid that day. And that was the driver for us to create televisits for farm workers. So when I think about how hard that was to establish that pilot and sitting down with the health plan and having an agreement, and then I think about everything we've had to do the moment we had to shut down elective surgeries, we had to shut down non-urgent ambulatory care appointments. So I would say that the future of healthcare, considering how much acceleration we've done, we need to move to at least a 70-30 model of non-face-to-face telehealth appointment ratio to in-person visits, and really the in-person visits being a lot more focused on acuity, need to be seen, high procedure type care. So that's something that I see happening, number one. Number two, to Mike's point, I think we need to find a way to bring in-home care and expand it. But the challenge is going to be in the COVID era. And what does that mean going into locations that you might not be familiar with, that are going to be different and not understanding the risk in those areas? But I think once we get past the upcoming surge that we're all anticipating in the fall, and then in time for the vaccines to start being piloted, I think we're going to start moving a lot more to in-home care after we go through ramping up telehealth visits being at least 70% of encounters. Those are two things I can see coming up very quickly. And then the last thing that I'm predicting is a deeper relationship between between health centers, health services, health systems, and communities. So what I can tell you is when I was leading the COVID Command Center, without community-based organizations, I mean, these are food banks, these are interfaith councils, these are people that own small businesses. Without community-based organizations, we would not have been effective in trying to get the citizens of San Francisco to social distance effectively, to mask appropriately, or to not be in non-congregate settings. I mean, community-based organizations were fundamental to us being successful in flattening the curve with COVID. So I anticipate that the relationship between communities, considering how much that relationship is going to be important for health promotion, especially when the vaccine arrives. That's going to be absolutely critical. So health systems are going to need to build a better relationship, more intimate, not even just better, a more intimate relationship with the communities they serve across the entire spectrum and across the entire socioeconomic ladder. So those are 3 things that I see happening.
Thank you so very much. So Irene, if I could go to you next, and that is, now that you have your crystal ball and you see where healthcare is going, how do you think, what are the strategies you think are going to be needed to implement whether your organization is going to go next?
Thanks, Joe, and thank you, Tosan, for your perspective. I want to take us first to a level of, even with the acceleration that COVID has presented and the idea of will visual calls to the patients, video conference calls to the patients, or phone, will that be our future in its greatest expanse? I want to take us back to the principles that guide what we do, and to ensure that whichever direction we're going in, that they're incorporated. And the first principle is that there always has to be a value proposition for the patient. The second is that we have to ensure that the processes are standardized so that we don't have aberrant rogue things happening, but that we have consistent, reliable processes that are driving positive outcomes for the patients. The third is that there is a predictable flow in the continuum. So whether you're a 70-year-old tennis playing senior or a 70-year-old homebound senior, that there is a progression in the flow of your care that you are an absolute partner in. And that's the fourth principle, which is to always engage everyone, engage your staff, engage the physicians, and definitely engage the patients. For us, we call that engaging our members, and we have a member advisory council. But in order to deal with the environmental factors that we're dealing with, which is the economic challenges that COVID has presented, with businesses closing, with the environmental threats of the fire and smoke that affects our patients, the political and race relation tensions that exist. And you think about that juxtaposition to video conference calls with members, and you lose the humanity of touching someone and making that real connection, not just the therapeutic connection of I'm your doctor, I'm your nurse, and I'm on the phone, but the touch piece. So we're really having to look for creative ways, innovative ways on how we stay connected to the heart of the patient so they don't feel the loneliness and the impact of loneliness during this time. Mike, want to add anything?
Well, I would say what you just described is really the great frustration that all of us who have, it's the reason that all of us who have tried to lure away Kaiser members are so frustrated because of that member experience and the continuity of care and all of the systems you have in place to take care of patients like that. So I would say I'm not surprised that those were really important principles, and I think Kaiser is just a really profoundly successful organization in that sense. I'll take it maybe at a different level, just kind of helicoptering up 100,000 feet, just to say in general, how do I think about, what are health systems thinking about in terms of positioning themselves for success in the future? I would probably break it down into four different areas, and particularly Irene said earlier, you know, change has been constant in healthcare. I personally feel like it's accelerating now, and the implications of the change now are more profound on our organizations and our patients than they have been. But I agree, it's been a constant. And so I think now, from a leadership perspective, more than ever, really making sure your organization has a compelling vision of what are you trying to do? Well, who are you trying to be? Because I think the theme of this this group is all about integration. I'm not convinced every organization is can be an integrated delivery system. I'm not sure every organization is trying to be an integrated delivery system. And as one aspect, I also hear a lot of organizations say, well, we're trying to have a foot in each canoe. So we're trying to be, you know, partly value-based care, partly fee-for-service. I'm not convinced that that's actually a strategy. That seems like avoiding making a decision in some way. So, so I think the first, a first element of really securing your organization's success in the future is make sure you have a compelling vision that does the things that Irene said in terms of making sure you're connecting to the consumers that you're caring for, and you have a standard of care or a model of care to deliver, and that differentiates yourself. And so that, I think that's really an important step. A second one for me is, you know, I think technology is going to play an ever increasing role in how we relate to our patients. I think the consumers in our markets, I think they're going to have different expectations of us in terms of how they want to connect with us, when they want to connect with us, where they want. Obviously, as Tosan just said, you know, we just had a huge boost, I hope an accelerant in terms of COVID and accelerating virtual care. I know Kaiser's been doing that for a long, long time. The rest of us are catching up. But I think technology from that perspective, we have to figure out how to make our providers' lives easier. Right now, the EMR is a huge frustration in all the documentation. So how do we optimize technology to make our providers' lives easier, to reduce burnout? And that's a piece of technology. Obviously, all of the clinical piece, there's so much to do with predictive analytics, with care at the home and home monitoring, televisits, disease management. There's all kinds of companies. I know you all are getting blasted with emails to look at different opportunities. And I think those are, honestly, I think the technology explosion to me is quite an exciting time in our industry. And unfortunately, right now, they're all super disjointed. They don't connect to your EMR very easily. And I think there will be opportunities to fix that. I think the third thing that I think about is, you know, given the change and given the sort of economic challenges we're facing, if you don't have lots of capital or a strong financial position, your degrees of freedom are fairly limited. And I think particularly, you know, as I think our organization, you know, we've been historically, you know, a fee-for-service oriented, hospital-centric system, and we're trying to migrate as fast as we can to a value-based integrated delivery system, and that comes at a big cost. There's a big transition curve in terms of your revenues and your expenses and et cetera. And so there's not a lot that you can do as an organization, but I just think having if you have a balance sheet or strong financial performance, it results in a lot more degrees of freedom. And the last thing I just say is your leadership team has to lead with like embracing change. As Irene said earlier, there's so much of it that if you just kind of try to dig your heels in and just hunker down, I think that's a recipe for failure. So those are my contributions to the topic.
So one thing that everyone has discussed consistently is change. And this year we have lots of change happening. And taking a question from the chat, somebody had asked, how about single payer? How does, I know we're not there yet, but with the acceleration of different things, we have to discuss it. So what are your thoughts? And I will go to Mike first, and then I'll go to Tosan, and then I'll go to Irene.
Well, my first reaction is, That scares the crap out of me. On the other hand, if I look at our payer mix today, we're well over 50% government payer in terms of net collections. In terms of gross charges, we're 80% government pay right now. So it's not that far away. If you think about,
Exactly.
if you think about the demographic changes going on, Medi-Cal growth in our state and the growing Medicare population. So we're actually not that far from there. Clearly, lots of details to work out between here and there because, our organization today loses money on every Medicare patient that comes into the hospital. We'd have to understand what all of the implications are. But so it scares me, but we're actually not that far away from that being a reality, a practical reality.
Yes. Tucson?
Yeah, I have a lot of feelings on this topic, and anytime with my friends, if we're hiking pre-COVID, I would always be asked this question. So I would say a couple of things. The idea of single payer is admirable, but I would share a couple of nuances. So as Mike just mentioned, yes, we're not that far off, but that doesn't change the fact that there's still a significant amount of people that are uninsured. And then there's also the reality that single payer tends to work well in countries that are homogenous, in countries that are not as diverse as the US, in countries that don't have the population of the US. And one of the reasons I appreciate the idea of a public option is because I think of it as education. So in the US, public school is available to everyone. And public school is an opportunity for, regardless of where you are in the socioeconomic ladder, you have access to an education. But if you don't like the education in your neighborhood, in your region, you can go to a private school, you can go to a parochial school, but you still have that foundation. And that is one of the things I appreciate about the public option, meaning that everyone has something, but then if you're not okay with what you have, you can opt out to get something else. And I think when we think about how we insure and cover people, we really need to think about how are we making sure that the people who have the least, the most vulnerable, still have access to care. One of the things that my father taught me when I was very young is you can evaluate a society on how it treats its most vulnerable. And I don't know that single payer is automatically going to be the solution when you consider the history of the US, you consider the diversity of the US, and you consider the size of the US population. I think a public option really does get us to where we need to be and making sure that the people have access to care. And when they don't like what they have, there's an option for something different. So that's my feeling of it, equating public education to a public health system. And keep in mind, I've spent the last 12 years of my life working for public sector, and where most of the people we take care of are the uninsured and are the undocumented. I mean, that's what I've spent my career supporting that population. So my insight on it is different.
Irene?
Thank you, Joe. So this is one of those topics where my personal beliefs are 100% aligned with the Kaiser Permanente official position, which is that we do not support single payer system, that we do support universal access to healthcare. My personal belief is that there isn't any one entity, including the government, God forbid, with the bandwidth to provide single payer solutions, not just to do it well, but to do it extremely well. That being said, I'm also a firm believer that competition is healthy. That if you're wanting the best outcomes and you have best practices at one carrier versus another, or one health system versus another, that those waters, the rising water, will lift all of the boats. If you limit it to just one, then the fleet's only going to go as fast as that one. And not a good scenario for the US health system. That's not who we are.
Great. Thank you. So we're going to get back to our agenda, and then we'll take another audience question right afterwards. So since we were talking about the pandemic a little bit afterwards, so let me ask you this one question. How has the pandemic impacted your organization's focus, especially when you're addressing workflow needs of healthcare providers in the digital area that can best be served for maximum quality, safety, and efficiency? So, Tucson, do you mind if we start with you?
Yeah.
Thank you.
So for many of you on the call, you might know this already. So I've spent the last 7 months leading the COVID Command Center for the City and County of San Francisco. And when I say I was living in the eye of the storm, I mean that quite seriously. So a couple of things that came to mind. The San Francisco Health Network, which is the provider for the City and County of San Francisco's care, meaning the public provider. San Francisco General had the largest COVID population in ICU and med-surg in the City and County of San Francisco. And when the command center was activated back in February, because we are the safety net of the city, a lot of San Francisco Generals, and then we also have Laguna Honda, which is our skilled nursing facility, a lot of the employees were activated as what we call disaster service workers across the entire city. And the command center of roughly 1,300 people were all government employees that were pulled from Parks and Recs, the library, and different areas to be in a command center. So a couple of things became very clear early on. First was, how do we manage our surge? In my role as the commander at the time, we needed to make sure that we had enough ICU beds, enough ventilators, enough med-surg beds to manage a surge of COVID positive patients, what we're calling as PUIs, coming into the system. Additionally, as a level 1 trauma center, gunshot wound victims were not going away. You know, as much as people were not commuting, that doesn't mean that every single type of accident was going away. People were still getting hurt. People were still getting sick. And we had to find a way as the safety net and the trauma center to make sure that we cared for those that absolutely needed it and were protecting capacity to be able to address the surge. So that was one piece. The second piece that we had to do was to ramp up testing. So how do we pivot our entire clinical laboratory and that's supporting a trauma center, and then pivot our entire public health lab that's supporting the entire city. So our public health lab does, like STIs and HIV analysis, essentially every major disease in the city. And these two labs had to become the foundation for testing in the city, in addition to creating contracts with One Medical and different things like that. So I guess a key theme that came across was being agile enough to be able to pivot when necessary, while placing the patient at the center of everything, every single time, was critical. Number two, patient flow can never, you can never take your gas off of patient flow. You always have to prioritize the takt time it takes from the moment a patient presents to the moment a patient is admitted to the moment a patient, is discharged. Keeping your finger on the pulse at every single step. And then I cannot, again, emphasize enough how much COVID forced us to really examine our relationships with the community, because it really highlighted that the behaviors that people are choosing to do every single day were going to influence the likelihood of contracting the disease. in the past 7 months. So we had to pivot quickly, and then stay true to the mission. I can talk about COVID forever because that's all I've been working on. But yeah, those are my thoughts right there.
Great. Irene, what are some of the workflows needs for healthcare providers in this beautiful digital era? Mm-hmm.
For the question. First, I have to say to Tosan that the fact that he mentioned Laguna Honda to me struck a wonderful reminder that I finished the book God's Hotel by Dr. Victoria Sweet not that long ago, which is all about Laguna Honda. Anybody who's looking for a bibliography and a book to read, I highly recommend it. It's outstanding. As far as the pandemic's impact on flows, on workflows, 100%. Everything really got turned on its ear, and we had to revisit it because buildings weren't impacted. We had to make sure that there was the social distance. We had to make sure that as people walked into the facility, that their temperatures were being taken and that we were asking pertinent questions to ensure that we did not have folks that were already COVID positive coming through the doors. And we had to deal with that big, horrible word called fear. Fear amongst the staff, fear amongst the public, and fear by the patients who were already in the hospital. And everything that we did in changing workflows, in putting up tents and managing how people enter the buildings and how we keep them safe, even in the cafeteria and the cafe, all were new and exciting workflows. When do you take an emergency patient to the OR without knowing that they're COVID or not? What workflow did that touch? And so I tell you, it was 100% of them. We have created an amazing master document of workflows and guides, and it stays refreshed. And it's a toolkit that is used by the managers in order to ensure that we are keeping everyone safe. And in addition to that, going back to the humanity piece of this, is as hard as our staff was working, the nurses, the doctors, and the ancillary staff, and we kept trying to show them how proud and how thankful we were of them, we also had to show where were we going to give them a place to take a break that was safe, and yet allow them that moment to just kind of decompress and relax. So we revisited every single square foot of the campus and created alternate settings. And it's actually made the campus look nicer, and the staff is most appreciative. So this kind of a situation, a pandemic, clearly called for all of us to weigh in.
Thank you. Mike, would you like to take a shot at it?
So many of the things Tosan and Irene mentioned, I can relate to it with our experience here at John Muir. I'll touch on a couple of things that both of them, that both of them had mentioned. One, Tosan made a big, said how important it was for his organization to collaborate with other community organizations. And one of the things I was really proud to see in our county was how the public health department and the different health systems came together to really avert what could have potentially been a huge crisis in our skilled nursing facilities and assisted living facilities. So John Muir got some calls from the public health department in early April there was a crisis, a big infection explosion at a skilled nursing facility in Orinda, and then another assisted living facility in Pleasant Hill. And we parachuted in our team of infection prevention specialists and nurses, and basically to do an assessment, to do education, to help work with patient flow and a whole bunch of things and stabilize the situation. But then we got together with the public health department, and we invited colleagues from the public health department, invited colleagues from Kaiser, from Sutter, and from San Ramon Regional Health System, and we all developed teams of nurses, basically SWAT teams, and we divided up all of the skilled nursing facilities in our county. And then we started with the assisted living facilities, and we sent teams of nurses out to each of them to do similar education and training, track their PPE supplies, do mass testing if that was needed. And really as long as I've been here, that's the first time that there was that level of collaboration with public health, and having public health sort of be a catalyst for organizing what was truly an amazing community response to COVID. And I think because of that, in our county, we had fairly limited, after those first two big explosions, we had fairly limited challenges from the skilled nursing facility populations and assisted living. So I hope one of the lasting impacts of COVID is that we've learned, the health systems with public health have learned how to collaborate in a way to address major health issues in the entire community. Just a couple other things that maybe, not to repeat what Irene or Tassan said, but we have a lot of employees working at home now, which I'm sure you do at all of your organizations. So we talk about impact of COVID on workforce and employees. We're learning a new way to manage and a new way to work with each other. So we have in the corporate office I sit in right now, it's been pretty vacant. It's probably at 20% capacity for the last 6 months. And so we're spending a lot of time talking about, well, how do we sustain a sense of culture, a sense of employee engagement, a sense of community with each other when we're doing what we're doing right now on this call, lots of Zoom calls, we don't see each other in person. Questions around how to foster collaboration in really, really meaningful ways to get things done, managing productivity. So I think that whole notion, it'll be interesting to see whether this workforce, remote workforce is a thing to stay or not. And similarly, using digital tools and stuff to engage our consumers. And, we have so many people in our community who are still afraid to come back to get healthcare. And how do you as community providers or in your organizations be the source of truth for your patients and address their health issues digitally is something that we're learning too. Televisits is just one aspect of that. But so I think those are probably two additive statements I'd say to the nuts and bolts day-to-day things that we changed to deal with COVID in our facilities.
So that actually goes into my next questions. Thank you, Mike, for actually making a great transition into that. And that is, I think we are all seeing the digital divide in our communities more and more. And we see how big that gap is. And with the transformation to telehealth and all the other innovations that we're talking about, the digital divide is one of the stopgaps to meet those populations. What are some of your thoughts that we could tackle that, or how do you see integrating that issue moving forward to be able to deliver care to individuals? And so, Irene, can I start with you?
Sure.
Thank you.
So there's no doubt that even for those that are Kaiser members, there are pockets within those populations that are struggling, and that access to a laptop or an iPad or an iPhone is a challenge. To Mike's point earlier, though, Kaiser has been using video visits and audio visits for a number of years. And our membership is attuned to it and used to it. And access to the phone has been probably the primary link to our nurse advice call lines, and secure texting to their physicians has been in place for the better part of 10, 15 years. So I think we bridged it, that terrible digital divide. And for those members who simply don't have access to any of that, and they have to come onto the campus, then we have to address for them that it's safe for them to be there and that they don't have to be afraid. And then to establish how are we going to communicate with you in the future to make it easier for you and to continue to meet your needs.
Great. So Mike, I'm coming to you next, and then we'll go to Tucson afterwards. What are some of the ways you think of integrating the digital divide in delivering healthcare, especially as health technologies that's what we're using now?
Yeah. So I probably don't have a lot of great insight on this, just because this is it. I think in 2019, our organization, this is an exaggeration, but maybe had 100 video visits. We had 50,000 this year, but that's all since probably April. So we're learning. We have, our experience to date is, our COVID response was focused in large part on making sure our most vulnerable seniors in the community were being taken care of in a way that we could avoid them having to come to the emergency room or the hospital, because we didn't want them exposed to COVID. So we spent a lot of our efforts on our telehealth response, targeting our elderly senior population with multiple chronic diseases, et cetera. And it turns out, not surprisingly, that population is not terribly technology savvy and stuff. And so we really struggled for a while to get, all the televisits and the digital connections and getting certain of our patients comfortable with that. I would say in the long run, I know the televisits will make us more efficient. In the short term, it hasn't made us more efficient, because we've had to have a lot of staff support helping with the patients to get on their Wi-Fi and log in and do all the things that you need to do. I'm convinced we'll work through that as we get more experience. But those have been some of the challenges. I would just say also, in terms of, I'm so excited about the televisits, but it's really getting us thinking about challenging our business model. And so how are our organization has a lot of investments in physical buildings that we have doctors in. And so just having a doctor sit in those buildings doing telehealth, and you have empty waiting rooms now, is not a really efficient way to provide service. And so we're starting to think about, what is the right model for telehealth? Is every doctor doing telehealth? Do we have a separate pool of doctors that are doing telehealth? Are we doing telehealth in the same facilities that we're seeing patients? So I think it's so new to us. We're starting to ask a lot of questions. We're not as experienced as Kaiser, who's been doing this a long time, but we are definitely committed to go down this path and are very excited by it.
Thank you very much. So Tucson,
thank you.
What
Jo.
are your thoughts?
So I've had the privilege of serving as a leader in two very different counties in the past 7 years, San Mateo County and San Francisco County, which are very different. And I bring that up because it really changed the way I look at the digital divide. And from my lens, the digital divide right now has 3 separate lanes. So the first lane really is about hardware, the access of people to be able to have cell phones, the access of people to be able to have computers, the access of people to be able to have the actual technology in their hands that's going to grant them the information they need, the education they need to make the best decisions for them. So that's one digital divide. Right now, technology is becoming more and more affordable, right? You can get, different cell phones. It doesn't have to be an iPhone, but you can get different types of technology at an affordable rate for families. So I think that part of the divide is easier to cross now than it was a couple of years ago. The second lane in the divide is what I consider like the software piece, and this is the internet. Not everyone has the same access to internet. Not everyone has the same access to broadband. Not everyone has the same access to be able to get the signals that they're going to need for the information and the education. And we need to find a way to bridge that. So this means finding ways to partner with, broadband providers to emphasize with city infrastructure. How can we improve access to internet? Because access to internet is access to information, which is access to education, which prevents people from showing up to the emergency room for primary care. People need to understand that you should not be going to the ED to go see your doctor. And a big piece of that is access to internet. And then the last piece, I think, is an area that, frankly, we haven't done a really good job on in the past couple of decades, and that's literacy. You can provide all the information that people need. They can have the technology, they can have the internet, but if people are still struggling to understand what does this actually mean? Should I go to see my doctor for this? What is the difference between going to urgent care versus going to the ED? How do I make sure that when I'm given directions, someone is reading it to me, teaching it to me, and in a way that I can explain it back and follow those directions? Those things are really critical. So my hypothesis right now in everything I've seen, and not to bring everything back to COVID, but in everything I've seen in San Francisco, which was a very different county from San Mateo, very different population, the digital divide always came back down to these three categories. And I think we need to find a way to address these three categories so that telehealth can truly be effective. Right now, it's been successful because we didn't really have a choice, but I don't know that we yet know how effective it has been in actually making sure people get the right care at the right time. It's something that we had to use, but I think the true test is going to be in the next year to see how effective our telehealth strategy is going to be. And I don't know that we can do that without crossing these three lanes in the digital divide.
Thank you so very much. So actually, I see a question that is actually near and dear to my heart, just because I do have a 76-year-old mother who is trying to learn how to do all these things, who lives in Sacramento, and trying to explain how to get on and how to get off and how to log on is just frustrating, which anyone could imagine who doesn't use a smartphone or any of those other things. So what are some of your organizations doing to work with seniors who need that special touch? We've had a certain amount of time to be able to work out a few bugs, and maybe it has been intense just because of COVID and the situation that we're in, that everything has to be telehealth. What are some strategies or some learnings that you've come with that? And Mike, if you don't mind, I'm going to start with you.
Yeah, this goes back to the comment I made about right now, telehealth is not making us more efficient. So we still have a pool of MAs who spend a lot of time with the patients ahead of time, notably the seniors, the one you just described as a common occurrence, where we have to get on the phone with that patient well ahead of time to walk them through all of the steps that they need to do to log onto their computer, and how do they get everything set up so that they're ready when the doctor comes on board. Now, obviously, the first time is harder than the second time, et cetera, but right now we have pools of MAs, if you will, that are doing kind of the pre-call prep so that everything's set up for the doctor. We have not sent people out to anyone's home yet, per se, to kind of educate them and check out all of their software and hardware activities. It's more on telephonic consultations.
Great, thank you. Tucson?
This goes back to the last thing I said about health literacy, and that's what I was getting at. So when we went live with Epic last year, August 3rd at 4:30 a.m., a big piece that we learned about was how are we going to make sure that our seniors, or for people that English was not their first language, or for people that were not technology savvy, how we're going to create time for them. And we ended up creating workshops where MAs, like Mike just mentioned, would spend time, in the clinic and trying to, teach the patients. But again, in a time of COVID, that's going to be even more protracted. So I think it goes back to what we mentioned in the beginning about how we need to, right now, I don't know that our electronic medical records are truly patient-centered or truly have a human-centered design to them. And I think we need to start there. And then again, going back to these 3 lanes I talked about, how do we make sure that health literacy is a key piece of it, where anyone can be able to find it intuitive to use the technology, making sure they have access to broadband. Because again, if people have access to broadband, their family members can also help prepare them to utilize this technology from wherever they're living across the world. When I think about my family, I'm an immigrant. So if anyone is an immigrant on this call, WhatsApp is the most used app on your entire phone, right? That is how you keep in touch with your family across the world. So my family uses WhatsApp to communicate anything that they're reading, identify any pictures. So we just need to invest in that part as well.
Great. Irene, is there something you would like to add?
Yes, I'd be happy to. So for many years, Kaiser has introduced the kp.org to its members by using ambassadors that were stationed at the entrances to each of the buildings. It helped us capture the picture of the members so that we could add it to the medical record to help protect against fraud. And we would do a tutorial to help the member. All of that was wonderful foundational work for where we are now. And so with fewer patients and members walking through the doors, and yet still acquiring new members, we thought, okay, now what? So we still have ambassadors that do the outreach to new members, to welcome them and to help guide them through the kp.org. And for the seniors, I was really pleasantly surprised when our manager for volunteer services, who also leads our member advisory council, said, well, since we cannot have our member advisory council meetings in person, we're going to go virtual. And I thought, oh my God, how are they going to navigate Teams or Zoom? And guess what? They did. She did a tutorial, and the first few were a lot of fun because people didn't know how to go on mute or didn't know where to place their camera. They could have used Sarah's expertise. She's so precise in that area for all of us. And yet they've gotten better and better with every session. And for the patients that we see that are homebound, that are seen by home health or by hospice, we ensure that, that they keep their skills set up on how to access the kp.org and all of its components. We also do the outreach to the community-based organizations because we have quite a bit of information that is public facing. You don't have to be a member to access it. That is quite helpful from a resource standpoint.
Great,
Thanks
thank
for the
you,
question.
Irene.
Yeah.
Thank you. So time is closing in on us. So I just want to do a quick time check for you folks, just because I know that there's some closing comments, and then we also have some things that that the chapter needs to mention before we close. So I have 2 questions. I don't know, we'll get to both, but one of them is that this is for Irene and for Mike. and we'll start with Mike on this question, and that is, partnerships will be necessary for sustainability into the future. Can you specifically talk about outsourcing and closer partnerships with vendors?
Yeah, so our organization has gone through quite a transformation in the last probably 7 or 8 years, and it had to do with a leadership change. So earlier on in my comments, I said, what do you need to be successful in the future? You need a leader with a very strong vision of what you're trying to accomplish. Before we had that leadership change, John Muir was a very sort of insular, internal focused organization. We brought in a new CEO, his name's CAHL, and he's still here. And he has a very external organization. And one of the conclusions he made coming into our organization was that John Muir does not have the scale to be able to do all of the things we need to do to care for our patients, and also to remain competitive in our competitive marketplace. So we concluded we wanted to stay independent. And so the question is, well, how do we achieve scale then? And so we actually committed that strategic partnerships were the way that we were going to create virtual scale, and outsourcing is part of that, which I'll mention in a minute. So some examples of that are we entered into a joint venture with a Tenet Hospital, San Ramon Regional Medical Center, which is down the highway with us. We're a minority owner of that facility, but that allowed us to extend our geography south. We entered into another joint venture with UCSF to the west, and that resulted right now in manifestation of a big ambulatory center in Emeryville. We entered into clinical joint ventures with Stanford Children's Hospital, where we brought pediatric specialty services into our facilities that are provided by Stanford physicians. We're doing a similar venture right now with UCSF around cancer services. We created, with UCSF, we were catalysts of creating a Bay Area-wide contracting network or accountable care organization called Canopy Health. That was our way to create regional scale for contracting. And then your outsourcing question, this is something, probably one of the bolder things we did, but we outsourced 540 employees to Optum about a little over a year ago. And those were in the areas of IT, analytics, and revenue cycle. So critically important administrative departments. But we concluded that we didn't have the scale to be applying advanced technologies and capabilities, et cetera, to run those as efficiently and effectively as a Fortune 500, Fortune 5 company in this case, in Optum. And so we entered into a 10-year agreement. We outsourced those services. We are also accessing different services from Optum. It's not really a joint venture. It is an outsourcing agreement, but it's long-term. So we do consider it a strategic relationship. So we are a big believer right now that we don't need to do everything ourselves, that there are really capable organizations, and the way that we can create scale and capabilities is to align with other organizations strategically, but not through merger. So we do have a fair amount of experience there.
Great. Irene, do you want to take a shot?
Sure. So there's no doubt that partnerships are critical, and from those partnerships come the contractual agreements. Examples for us are in the area of mental health. We do not have a psychiatric hospital within the Kaiser system, with the exception of a small HUF at the Santa Clara campus. So we contract out the majority of the mental health admissions to a variety of partners. We also contract with Valley Medical. They have an outstanding physical rehabilitation program, and we do not offer that service within the South Bay. There is one in Vallejo, but many times the members prefer to stay closer to home because they want their families involved in that rehabilitation journey. We also have contracts in the Santa Cruz market with Watsonville Community Hospital because it was not and is not our intent to build a hospital there, and worked with them, and they've been a wonderful partner. Outsourcing is always an interesting challenge. We outsource the management of environmental services to Xanatos, and the dietary services to Morrison's, and they've done a great job for us. So each opportunity is thoroughly assessed with implications for excellent outcomes and implications for our staff and our labor relations. And most of these decisions are made jointly and collaboratively.
Thank you, Irene. So for our final question, and I just want to make sure that that our panelists know that we actually have to start wrapping up at about 6:55. So just a warning, I may keep you, I might shorten your answers and step on a little toes here, but we need to make sure that we end on time. So one of them is that our very last question, and that is, it's a big one. So it is, what action is your organization taking to address justice, equity, diversity, and inclusion issues related to the workforce and patient population? So as I mentioned, it is a big question. And so Tucson, I'd like to start with you, please.
Yeah. I guess the first thing I would say is I have come to believe that health equity and hospital interactions should be intertwined for multiple reasons. One of them is it's good for business, meaning that your staff feel valued when equity is front and center because they feel like they can bring their whole selves to work. You are more likely to recruit physicians and staff from different backgrounds when they know that you're an inclusive organization. But last but not least, and the most important reason of all, I don't know that you can truly say you're successful in quality outcomes if there's disparities in your patient population. That's why I believe that health equity and hospital operations should be intertwined. And I say that because I want to emphasize that, we've reached a point in the U.S. where health equity has become, I would say, crucial in hospitals and clinics and FQHCs and different and health plans. So speaking at the General, at San Francisco General, we have an equity strategy. It's been live for almost 4 years now. I'll just talk very briefly about 3 pieces of it. The first part is making sure we have the data and infrastructure to have race, ethnicity, language, sexual orientation, and gender identity for all our patients. I'm very proud to say that when we started in this journey, we now have that information for over 90% of our entire patient population. So that's the first part of the strategy. And the second part of the strategy is stratifying our quality metrics by starting with race and leading with race, because research has shown over and over and over again that race is has the most significant determining factor when it comes to outcomes. And we've successfully stratified quality metrics for all departments. Right now, say 77 departments, 77% of all the departments of San Francisco General have stratified their quality metrics by race, ethnicity, language, or sexual orientation, gender identity, and in some cases both, and have developed plans to, when you determine a gap, what is your plan to close that gap? And then
Thank you. I'm sorry. I'm sorry, we're gonna have to.
The third part of the strategy that I'll just say is, I think it's really critical that when you're doing equity work, you have to look at the workforce as much as you're looking at patient outcomes, because yes, patient outcomes are extraordinarily important and probably the most important, but I would argue that just as important, understanding your workforce is going to be really critical, because the research also shows that staff engagement drives patient experience, and we really want to understand the workforce as much as we're understanding disparities in patient outcomes.
Thank you. Mike, I'd like to go to you next, and then Irene.
Yeah, so this has been a topic that's been on our agenda for some time. We have a number of task forces, LGBTQ, racial equity, gender equity, mental health. We got a bunch of affinity groups. But the truth is, the leadership of our board and our executive team really became energized on this topic a few months ago. So we are trying to energize all of these efforts. And where we're at right now is actually we're meeting with all of these affinity groups and task forces, and we set up basically listening sessions for them. So we've trained employees in each of these task forces or the affinity groups, and we've trained them to be facilitators to, how do you listen and how do you identify key issues? And then we've been having a process to debrief with them, and we're already starting to make some changes because of that. So for example, one of the feelings that, or one of the pieces of feedback we got back was there's no senior executive that is accountable for this, and there's no real department that we had. We had, these task forces and affinity groups. So we created at the request of our employees an Office of Belonging and Equity, which its own leadership and staff structure. It reports up to our Chief People and Engagement Officer, who is on our executive team. So right now we're gathering a lot of information from all of these groups to say, okay, how do we want to prioritize our efforts? One of the things we're doing is we also have a Cultural Understanding Advisory Committee that's been around for a long time. Prior to July, there were 30 members. We've recruited another 90 members since July to that group, and that group is also informing this Office of Belonging and Equity. So, just another example of things that are coming out of that process of the listening sessions. There were comments about our policies need to be revisited, and we're going, well, okay. And the example was that one of the employees gave us was our sexual harassment policy is very exacting in terms of behaviors, what you can do, what you can't do, what you can say, all of those things. But when you look at our anti-discrimination policy, it's fairly vague. It's not really clear about the behaviors and particularly in contrast to the sexual harassment one. So we are going through a process now of re-looking with members of the committee at all of our policies and procedures. So I would say we're on a journey. There's no question this has the attention of our board and executive team. And it's going to be a permanent part of our executive leadership agenda now.
Great. Thank you so very much. Irene?
Thank you, Joel, and a great question. So I'm going to focus on the equitable inclusion piece of the equity, inclusion, and diversity dialogue. I was impressed and moved from Texas to California to join this organization because all the way from the board level, there are women and there are people of color that are on this board. And when I look at the medical center and I assess, does our staff and does our medical staff represent the community that we serve? Our community is primarily about 31.5% Hispanic and about 30% Asian. And we then compare that against staff and physicians. And on staff, the answer is absolutely yes. On physicians, it's still a journey. We do not have enough Hispanic physicians that are still bilingual and bicultural. So that's a work in progress for us. There's no doubt that business related groups like Kaiser Permanente, Latina Association, or African American Association are all focused on helping us achieve this goal. And I would encourage every organization to have strength in its equitable inclusion. And the last thing I'll say is we've invited Shola Richards, who is an amazing speaker and leader to have a discussion with our team about racism, because unfortunately it does exist amongst our members and amongst our staff. And being able to talk about it boldly is one way to gain better understanding and compassion for each other. Thanks.
Thank you. So I know that we'll be wrapping up in actually we have like 2 minutes left before I hand it on over. So knowing that there's 2 minutes left for our panelists, the question that I have, the final question I have is, how do you see the future going forward? Like what do you think we have in store for us? And so Tucson, I'd go with you, because you look like you have a little smile on your face, like you might know something.
I was smiling at how large your question was for 2 minutes. Right now,
You each get 30 seconds. No,
okay,
please
the future
go.
is very blurry right now, and COVID is going to be with us for a bit, and we need to do everything we can to make sure we survive it, come out on the other side, and really figure how do we thrive in a pandemic and make sure no patient gets left behind. We cannot play catch up to a pandemic the way we did in the spring. We cannot afford to again. And research and nature has shown us that something like this will happen again. So we need to be prepared for it next time. And at the same time, meeting our patients where they are versus us expecting them to come to us.
Got it. Irene?
Thanks, Joe. So I see the future rather optimistically, because I'm blessed to work with an amazing team of young executives that only want to do the best, and that's for the patient. So our country is an amazing country at adapting to whatever challenge is posed and to find innovative solutions. And we're simply microcosms of that. So it's optimistic, and I'm delighted to be a part of it.
Great. Mike?
Yeah, I would say I'm super optimistic. And I think Irene's opened up the evening saying change has been a constant. That's true. But I think, in my opinion, never before have all of these forces converged to create an opportunity to do something dramatically different in healthcare. We all know that there are problems. There are problems with equity, health equity and access. There are problems with we have a doctor-centric delivery system in some cases, very dependent on bricks and mortar, not designed in all ways to meet the needs of patients. So the convergence of all of this new technology that's coming out, financing changes, consumer expectation changes, employer demands, the government forcing changes. I think this is a really exciting time in healthcare, because I'm thinking that there is going to be really transformational changes that all of you get to help drive. So I hope you're embracing this opportunity and this time.
Thank you. And thank you to our panelists, and thank you for all of you. Really appreciate it. It is actually my favorite season, being a political junkie and working in advocacy right now. So please remember to go out and vote. And Lillian, please.
Thank you, Joe, and to our wonderful panelists, Mike, Tosan, and Irene. What a great opportunity to hear about significant issues for healthcare executives, healthcare leaders. I also want to add my thanks to our platinum sponsors. That includes Gurnick Academy, University of Phoenix, UCSF CAHL program, and Aya Healthcare staffing. So without their support, we couldn't be able to put on a program such as this and make it something affordable for participants and be a part of the learning that each one of us has had. So one of the things that I know that teachers say to really reinforce a learning is to apply what you just heard or what you learned, and identify a couple of areas that you want to take these messages and saying, hey, how could I incorporate that into my leadership or my management, or in my with my team or in my organization. So hopefully you will really think about the things that you learned tonight and apply those. And then there's a slide that talks about in a couple weeks, we have a next program called Wellbeing for Healthcare Professionals. And this is really important because we did talk a little bit about mental health, and in our caring professions, it's sometimes hard to care for ourselves. And maybe we're going to learn something new about how we can be better at focusing in on the needs of our healthcare professionals who have been working extremely hard in very uncertain times, not only with COVID, but right now with the fires that are ringing around the entire Bay Area. So hopefully you'll register for that early and participate in that one. We look forward to having you join us again. And thank you for everyone who was part of this program. Thank you so much to our panelists and to our moderator. Good night, everybody.
Good night.
Thanks, Lillian. On behalf of ACHE, I want to thank our chapter leaders that planned today's session, our moderator and panelists, and all of you for your participation. Please complete the course evaluation by visiting your My ACHE page and selecting My Online Learning from the Helpful Links section on the right side of the screen. From there, click on the Access My Courses link, and you will be directed to our learning management system where you can complete the evaluation. In the same location, you will be able to access the recording of this session within 48 hours. Your face-to-face credits will be posted to your My ACHE account approximately 2 weeks following the session in the My Education Credits section. That concludes our session, which is copyrighted in 2020 by the American College of Healthcare Executives, all rights reserved. Thank you, everyone. Have a wonderful evening.